In this lecture, I'm going to talk about retinopathy in latent autoimmune diabetes of adults, or LADA. So the association between retinopathy and LADA has been shown to be genetically linked, as it is linked to the locus of HLA DQB1. So, but first I would like just to give some definitions. For example, glutamic acid decarboxylase. This is an enzyme which is present in cytoplasm of human beta cell, and it is required actually for gamma aminobutyric acid synthesis that acts as neurotransmitter in neurons of central nervous system and in pancreatic islets, and probably it involved in controlling the release of insulin from secretory granules. So patients with LADA, or latent autoimmune diabetes in adults, usually these patients, they are elder, maybe above 35 or above 40. So usually physicians or medical doctors, they put them on oral treatment, oral hypoglycemic treatment, but they may not get benefit from this oral hypoglycemic treatment. And as I put them on oral hypoglycemic treatment, because the presentation is late in age. For example, if a patient presented with diabetes at the age of 45, so he has a diagnosis, it could be type 2 diabetes mellitus. So they put them on oral or oral hypoglycemic agents. However, these or some of these patients may not get benefit from oral hypoglycemic, and so here we should investigate them for the possibility of LADA, which is an autoimmune disorder. So it is, yes, diabetes, but it is not type 1. It is not, because the onset is late in age, and it is not also type 2. It could be type 1.5, and here we should investigate that patient to just approve the diagnosis. We should investigate patient for some antibodies, and we have here antibodies to this glutamic acid decarboxylase. So appearance of antibodies to glutamic acid decarboxylase number 65 is a marker for LADA, or latent autoimmune diabetes in adults. So the latent autoimmune diabetes in adult, as I mentioned, that it is genetically linked to hereditary autoimmune disorder that develop in adults, and it is linked to DQ, the locus of HLA DQB1. So adults with LADA are frequently initially misdiagnosed as having type 2 diabetes mellitus. This based on age rather than etiology. So LADA is distinguished from type 2 diabetes mellitus by the presence of islets antibodies or autoantibodies to islet cell of Langerhans. So these autoantibodies, they are very important to know them. These are glutamic acid decarboxylase 65 autoantibodies, or beta cell specific autoantibodies, or an insulinoma antigen 2 IA 2A antibodies. So if a patient presented with no response to oral hypoglycemic, so the physician should investigate by ordering these antibodies. So we have a criteria, diagnostic criteria. It is by the Immunology Diabetes Society. So has proposed the following criteria for diagnosis of patients with LADA. So these criteria, patients should be at least 30 years old or of age, at least 30 years old of 30 years of age. And patient should be positive for at least one of the 4 antibodies commonly found in type 1 diabetes. For example, islet cell antibodies, ECAS, or anti-glutamic acid decarboxylase 65 antibodies, and this we have it actually in Sudan, or insulinoma associated antigen 2 IA2 antibody, and also not treated with insulin within the first 6 months after diagnosis. And of course, some patients with diabetes may present with very severe infection, so physicians tend to put them on antibiotics, and in some instances they put them on an insulin. So accordingly, LADA is often misdiagnosed and treated as type 2 diabetes, and this results in insufficient glycemic control, and the patient may develop serious complications, for example, retinopathy, which is very serious complication. So all patients with diabetes mellitus type 2 and who do not respond to oral hypoglycemic treatment should be investigated for latent autoimmune diabetes of adults, or LADA, by the autoantibodies I mentioned, autoantibodies I mentioned above. So LADA patient may initially respond actually to oral hypoglycemic, but maybe during the first couple of months may show some response, but that response for sure is not enough if he is a true case of LADA. For that reason, insulin therapy is required as soon as the diagnosis gets established. So a reliable test for this, as I mentioned before, include anti-glutamic acid decarboxylase 65 antibodies, and islet cell antibodies, and insulinoma associated antigen 2 antibodies. So luckily enough that glutamic acid decarboxylase 65 autoantibodies show no correlation with age and at onset, and is therefore a particularly attractive marker for autoimmune diabetes in the adult population. And the most important to put in mind, and this warrant many things, so that a patient with LADA and these antibodies are positive, glutamic acid decarboxylase reactive or autoantibodies now are positive. This patient should be immediately refer to the ophthalmologist to check the eye, because the association between the glutamic acid decarboxylase autoantibody positivity and the retinopathy has been shown. So there is an increased prevalence of retinopathy in patients with positive glutamic acid decarboxylase autoantibodies as compared with those with negative glutamic acid decarboxylase antibodies. This actually our advice, just to refer him to ophthalmologist. So the study, this by us actually, by LADA and others, reported the prevalence of glutamic acid decarboxylase antibodies among Sudanese patients clinically classified as type 2 or as having diabetes mellitus type 2 as a diagnosis, and were on oral hypoglycemic agents, and they actually did not get benefit from the treatment. I have seen one of these patients, her fasting blood glucose was very high, too high actually, and they put her on oral, and just they tend to increase the doses of the tablets every then and now. So my advice is that we should investigate that patient, and we wrote to her to go to the lab, and we order for her antibodies or glutamic acid decarboxylase 65, number 65 autoantibodies, and the result was positive. She was actually 50 years old, 50 years old, and we decided to put her on insulin, as the diagnosis now, it is approved by the autoantibodies, and she was diagnosed as LADA, and I have seen that patient at GABA hospital. So accordingly, we advise a dilated eye examination in patients with LADA, all patients with LADA, as a higher proportion of subjects with LADA had evidence of microvascular complication of diabetes mellitus, namely retinopathy and neuropathy. So immunological method for diagnosis of this autoantibodies. So ELISA, it was a useful immunological method, and has the capacity to differentiate between LADA patient and type 2 diabetes mellitus. So the treatment, as I mentioned, that it is actually shift from oral hypoglycemic to insulin. But however, early treatment with insulin, in the absence, for example, of glutamic acid decarboxylase is not required for at least 6 months after diagnosis. But however, we can put the patients immediately on insulin, and the justification for that treatment approach with insulin would allow beta cell Langerhans, would allow rest for this, as they are under stress all this time, at least in part by down regulating the beta cell metabolism, or by releasing them from the hyperglycemic stress. So as a result of this, that we put the patient in insulin when we diagnose the condition, is a decrease in the severity of insulitis, and so we can avoid serious complication, for example, retinopathy. So LADA patient with insulin resistant could benefit. So of course, we shift from oral hypoglycemic treatment or agents or medicines or tablets to insulin. But however, some patients, not all, some patients also may show some resistance to insulin, and in this case, or in this condition, or this instance, we put the patient on metformin or glitazones. Thank you very much, Professor Ahmed Bolad.